A lot of people tell me that their doctors dismiss their symptoms as being all in their head. But having spent many days by the side of doctors who are diagnosing and treating RSI, I can tell you that they perform actual clinical tests that reveal the presence of an injury. This is important because you need to catch repetitive strain injury early in order to prevent chronic problems. So here to reveal, how we can understand this issue of is it all in your head or is it a real thing, is our medical expert, Dr. Robert Markison, a San Francisco hand surgeon, renowned in this area. And so, Dr. Markison, people can have very strong reactions to a physical injury, particularly to the hands. So how does the doctor know that this is physical rather than psychosomatic?
Well, first of all, make some eye contact in addition to physical contact safely in the age of coronavirus pandemic. And you're in effect trying to get a sense of the psychophysical nature of one, their expressed problems, and two, who they are and how they feel about work and how they feel about life itself and what limitations they perceive in both. And so getting to know the patient, getting your hands off that dreadful electronic health record laptop and making true heart, mind, soul, hand communication is worth its weight in gold.
So can you describe some of the tests that doctors use? I mean, I'm very familiar with the dynamometer, the grip test strength. And that's interesting because you don't always know that you've lost grip strength.
Absolutely. I mean, you could separate it into two and perhaps three parallel pathways of inquiry, apart from the interview and the real true history, not only of the trouble, but medical history and social history, living situation, household chores, scope of self and upper limb use, in and out of work. But beyond that, clinical neurological examination, essentially neck and really brain, but neck to fingertips. So thematically, cervical spine, brachial plexus, any possible peripheral entrapment of nerves, carpal tunnel, but many more possibilities. That's one pathway of inquiry, absolutely necessary. Two, looking for anatomically discrete inflammatory conditions. That could be somewhere between neck and fingertips, including cervical spine degenerative disease, congenital problems leading to pain, problems in the cervicothoracic regions, working all the way near to far out to fingertips to figure out the regions of trouble. And then rather than say RSI, which is a wastebasket term in some ways, anatomical diagnoses whenever possible, because obviously diagnosis will specifically drive treatment. Then the third pathway of inquiry is something outside of RSI, which could be indeed troublesome. And that might be anything from a little skin cancer, squamous cell cancer, the things that you would pick up, lumps and bumps, Dupuytren's contractures that draw the fingers down, these kinds of things, congenital anatomical variations predisposing to trouble, congenital linkage of tendons and so on. So chance will favor the prepared mind of the examiner as that person is looking for anything else, not just simply wear and tear.
One of the things that fascinated me when I was sitting with doctors was they could feel a bumpy, inflamed tendon. It was sort of a tactile thing. And I thought that was really fascinating that you can actually palpate an injury.
Well, yes, sometimes you can, and clearly describe inflammatory conditions such as de Quervain's stenosing tenosynovitis, where you have thickening of tendons and you might feel a little irregularity. Flexor sheath tenosynovitis, which can turn into trigger finger with irregular movement. Those kinds of things you can tell. I guess I was the first to publish use of a pediatric head infant stethoscope to listen to tendons gliding through their paths. So I have good pitch sense. Many people do.
Wow.
And I'm
So you
listening
could
for
actually hear the
That's right.
brain.
One sec. So why wouldn't you, if you listen to hearts, why couldn't you listen to hands? Very simply.
Wow.
So I guess I published that circa 1989. But in any case, just listening for harsh, high-pitched, irregular sounds, obviously comparing neighboring digits and the opposite uninvolved hand. And so that's a world of information as you listen to things glide and you're attuned to the sound of dynamic anatomy in and out of inflammatory conditions.
That is so fascinating. It's almost like a whale sound or something. I mean,
You've got it. You've
but
got it. And it should be
using
a
all
low
the
pitch.
senses.
Oh, well, you have to, of course. I mean, you're born with them, or most of them. Why wouldn't you use them?
Well, I mean, sometimes when you're in the doctor's office, you don't always get the sense that you're being seen or heard or felt, you know, in these senses. But there are other tests too. I mean, there's Finkelstein maneuver, all these different tests. Can you talk a
Right.
little bit about them?
Sure. I mean, if you're looking at cervical radiculopathy and look at Sperling's maneuver, wherein the head goes up and out, examiner gently applying a downward axial load on the spine and asking whether that causes any symptoms in either upper limb cervical radiculopathy. Pressing on anterior scalene lower trunk of brachial plexus here and asking whether that reproduces, or amplifies symptoms, thoracic outlet syndrome and or other brachial plexopathies. Then pectoralis minor origin over top of the plexus, the forward reach in a keyboarding situation and other situations could irritate the brachial plexus there as it's starting to branch, ramify into peripheral nerves. Cubital tunnel syndrome, where you compress the ulnar nerve on the near side throughout and beyond the cubital tunnel to ask about numbness and tingling, little and half of ring. Then the array of carpal tunnel tests, but before you myopically focus on carpal tunnel, you always consider the possibility of other entrapments, and others would be ligament of Struthers, Lacertus fibrosis, pronator teres, superficialis arcade, and anterior interosseous nerve with weakness. And then you get to carpal tunnel, and George Phelan, who published the massive series, 659 cases, 1966, Cleveland Clinics, George Phelan gave us Phelan's sign, wherein you go like this and thereby tighten the carpal tunnels to see if that produces or increases numbness, tingling, thumb, index, middle, and half of ring. Median nerve compression testing, Durkheim described it in San Francisco, compression testing on the nerve on the near side, proximal, throughout the carpal tunnel and at the end of the carpal tunnel to check that. Also stroke sensibility, comparing sides, 2-point discrimination, where you ask the patient who's not looking at his fingers whether they feel 1 point or 2 points throughout, normal being up to 6 millimeter point spread with the varying distances in the little caliper, 2-point discrimination. Or Sims-Weinstein monofilament testing, another excellent test for sensibility in the fingers. Also another clinical test, dryness, because sweat fibers parallel sensory fibers and peripheral nerves, such that as soon as you start to block nerve signals, you can start to get dry. And so I guess I describe the pen drag test, wherein you drag the smooth surface of a pen, and if it's gripping and moving the tissue, then obviously you've got the combination of fingerprint topography and sweat, which lets you grab. When you're dry, you drift across as you would silk or cotton fabric. Otherwise, you may indeed, by palpation feeling, note that something's moist and naturally moist, others robbed of sweat because peripheral nerves carry sweat and sensory fibers together. And then you also look at Tinel's sign. What Tinel described in 1912 was just tapping on a peripheral nerve that's compressed to see if you get a little zinger, little electrical sensation. So that's the array of clinical tests within the carpal tunnel, or maybe cubital tunnel, or radial tunnel syndrome. So you're checking these various things, and then you have to do motor testing. And muscle testing is extrinsic muscles living in the forearm, activating the hand, and intrinsic muscles that live within the hand. The radial nerve has no intrinsic innervation, but you do check it up here. The ulnar nerve, however, is the nerve of dexterity running behind the funny bone. And so you're checking the 15 out of 20 small muscles served by the ulnar nerve. That's the spreaders, that's the bringers together. That's the power of pinch with the adductor pollicis, most powerful, large, massive muscle in the hand. So you're checking all these little things, really, literally little things, intrinsic, extrinsic muscle testing for median and ulnar nerve, extrinsics for radial nerve, recording whether it's normal 5/5 or something less in power. And so you've really got a fair number of metrics. Then you include strength, which is typically the JMAR dynamometer. Okay, so you're checking grip, rapid exchange grip strength testing to look for consistency and certainly for full effort versus minimal effort. You're also looking at the pinch meter because that metric is important, the power of pinch. There are normative data, obviously, for ages of people and so on, various conditions. And it's been shown in a lot of simple but important global literature that your strength is going to be significantly determinative of your lifespan. The strong shall truly survive. You don't have to be a weightlifter, but the point is if you have a significant grip or pinch strength drop off through life, life itself could drop off.
I have a question. There's also, when you're talking about listening, there's the test where you hold your arm up, turn your head, and the doctor is listening to your pulse. And that, I believe, is for thoracic outlet syndrome.
Yeah, thoracic outlet syndrome has a multiplicity of tests, Wright's test, Adson's test, and so on. You palpate the radial artery, the pulse right here, as the chin is down on the same shoulder, down on the opposite shoulder, which can potentially block inflow, which is the subclavian arteries, which become brachial, radial, ulnar arteries, and so on. But you're checking for pulse diminution. But at the same time, when you're doing that, you also listen. And again, I love the pediatric head of a stethoscope to listen for turbulence in the subclavian artery above and below the collarbone to look for vascular thoracic outlet syndrome. You know, thoracic outlet syndrome comes in various flavors: inflow, arterial occlusive, which was described in actually the 19th century, or more commonly, neurogenic, which is nerve compression, and also somewhat commonly, venous and lymphatic outflow obstruction, any of which can cause trouble at plexus level, radiating out into the upper extremity. But here again, anatomical variations abound in the upper limb. There are 38 primary anatomical variations of the brachial plexus without promise of symmetry, with infinity in between. And as a surgeon who did a lot of trauma surgery through the 1980s, including stab wounds, gunshots, and so on, it was a matter of putting atypical spaghetti together under a microscope for 12 hours, realizing that the books showing one version of normal were seldom relevant. We reviewed the neurological tests. Obviously, there are tests for inflammatory conditions. If the thumb is getting stuck, clicking, snapping, it's called trigger thumb. You would want to check for that, or trigger digits. You also check Finkelstein test for de Quervain's, which is forcing the tendons that go out to the thumb, abductor pollicis longus, extensor pollicis brevis, and then further forcing the knuckle joint, which is extensor pollicis brevis only, to see if you have not only a tight tunnel here, not carpal tunnel, it's called de Quervain's, but also subtunnels within. 60% of patients undergoing surgical release have a congenital anatomical variation of double-barreled, not single-channel tunnels. And so looking for anatomical variations, looking for inflammatory things, never assuming with a tendonitis that there isn't anything underlying it. So you grind test with axial load, pressure, and movement to see if there's thumb arthritis. 25% of women over age 50 will have it, 15% of men. Thumb carpometacarpal joint or other joints, osteoarthritis. And so these various tests are extremely important in that parallel pathway of inquiry that includes looking for anatomically discrete inflammatory conditions.
You know, Dr. Markussen, you talked about the idea of listening to the whole patient, and you're being okay with listening to the emotional aspects of someone who's been injured. Can you talk a little bit about your approach to this?
Yeah, actually, I was pegged to become a psychiatrist in med school, and I was interested in the so-called normal mind and its variations. was exposed to everything from postpartum psychosis to you name it, and have a fondness for the nature of mind and cognitive neuroscience, neurobiology, and what makes us tick. But beyond that, I'm very aware that some people carry a negative self-fulfilling prophecy in their hearts, um, wanting to be sick and rock the cradle full of pain. And I certainly understand that. And I don't judge them as lesser beings in any way, shape, or form. But the question is whether they are unduly engaged with pain as opposed to a little more plus spin without being cockeyed optimist. Um, and so I'm trying to figure out in that duality of optimism, pessimism, positive psychological being, negative depressive affect with anxiety, where they might fall. And again, this isn't judgment. I mean, it's absolutely essential to find out how they relate to pain and talk about what was the appendectomy like, what was the this or that like. You had a little biopsy here and there. Was that trouble healing? To get an idea how they got through little physical surgical scrapes, which is somewhat telling. Oh, you had a fractured limb and lower limb, and how'd you get through it? Crutches, walker. I mean, are you independent free living? Are you dependent living with others and or institutionalized? These are very important things to hear about. Also, the holistic matter of what do you eat, going with Hippocrates and food is fuel, food is medicine. Do you drink alcohol? If so, how much? Do you smoke? Smoke now, smoke previously? Are there recreational drugs in progress? Do you take vitamins? Do you have a primary care doc who may have checked vitamin D levels and so on? So the most common overlooked cause of depression nowadays globally is vitamin D deficiency. But there are other deficiencies that can lead to depression, lead to nerve problems and so on. What medicines do you take off the shelf, over the counter versus prescribed? Are there single agent polypharmacy related drug side effects that are fully causative or possibly contributory? Pre-diabetes, a little extra weight during the pandemic. Have you shed that weight or is it increasing, since we know there's a 3.5 to 4.1x increase in carpal tunnel with extra weight, including fat crowding of the tunnels and so on. So just getting an idea of their self-concept, history of surmounting trouble, and intended or hoped for futures. So that sounds like a lot, and I'm not posing as a psychiatrist, and certainly refer to psychiatrists who are sensitively aware of the whole thing as necessary. Um, some people wish their way into trouble because they hate their job and don't like their life so much. Others will do anything to get out of it. As a surgeon of some experience, I'm operating on my peers every week now, releasing their carpal tunnels, releasing their trigger digits, releasing tendons around the wrist. This is wear and tear from hard work in ORs all day and all night. And I know who they are. I know their personal career thrust, and that they'll do anything to prolong their work span and independence.
You know, there's such an interesting, I've discovered just anecdotally that a lot of people with RSI, even thinking about touching a keyboard can trigger their symptoms. And I think that's kind of a friendly thing. You know, like it's your body knows, don't go there. You're not ready. You know, don't do the repetitive thing that got you into trouble. So in that sense, I think the mind-body connection can be your friend and sort of keep you out of trouble. The other thing that I've noticed is that sometimes when people, you know, I teach an exercise program and their mood lifts, they have fewer symptoms, their outlook is brighter from the fact that they're moving in a holistic healing sort of way. And so it's an interesting thing. I don't always see it as a bad thing that the mind and body are so connected. And I feel for people who are dismissed by their doctors because the doctors aren't seeing sort of a bigger picture, or maybe they don't know very much about repetitive strain injury, so they don't know what they don't know.
I agree with that, but in simple business terms, RSI patients are very time consuming. It's relatively uncompensated, unreimbursed. And so a lot of doctors frankly don't have or want to spend the time, and they've got a spectrum in their head based on worst case scenarios. You have belly pain, is it appendicitis about to burst? Are we going to the OR within the hour? versus, oh, you've got some aches and pains. That's the nature of life in a gravitational field. Suck it up, buck up, soldier. And so there's a whole spectrum of things everyone's looking at. Oh, I have a headache. Well, I'm looking at your pupils. One is blowing. You've got something causing pressure requiring decompression of the brain today, as opposed to, oh, you've got a headache. And so you have to be very careful as a physician that you don't be cavalier, self-conceived as bulletproof. And why isn't the rest of the world that way? You want to approach every human being in an informed, humble way.
Thank you. Thank you for explaining all of this. It's absolutely fascinating. So we look forward to seeing you soon, Dr. Markuson.